Hi everybody. Hope you can all hear me. Um, yeah, I was just giving a chance to those who maybe were joining a bit late or maybe having trouble connecting or things like that. Thanks so much to all of you for joining this evening. And hopefully we can have another great session. So we're going to go through another relatively basic, when I say basic, again, I mean an ECG that we should know working in emergency departments. So listen, if you guys have any questions, you're more than welcome to stop me. You can type on the chat, or you can just ask your question directly, whichever it is. I don't really mind. Okay. Yeah, but otherwise, if it's okay with you guys, then we'll start. So I hope you'll had a chance to have a look at the ECG that I had posted a bit earlier. So if you didn't, it's not a problem because we'll go through it now step by step, and then we'll try and figure out what's going on with our patient. So we have a 54-year-old woman complaining of mid-sternal chest pain and lightheadedness. And I used to always like the exercise of you're on call, it's late, let's say 5 in the morning. You happen to be in your car or in the duty room or in the restroom or whatever it is. Your sister calls you and she says, listen, we've got a 54-year-old woman complains of mid-sternal chest pain and lightheadedness. So your immediate thoughts are, okay, I'm coming, I'm dedicated. I'm going to, let's see what my differentials are. Now, in truth, most of us will go wake up and say, couldn't this have happened after my shift? But in any case, let's pretend we are very dedicated and we actually start thinking of differentials when we wake up at that time of the morning. All right. So mid-sternal chest pain, you immediately would go to something cardiac. So whether it be an MI, whether it be an anginal episode, or whether it be what aorta, something like that, then, a pulmonary embolism, those would be the types of things that you would think about. Okay. Um, yeah. So, sorry, I thought I heard somebody over there.
Go to the bed. I'm not, you know, maybe some sort of gas.
Oh, okay. I can hear something from, it just says Nkosi's P30. I'm not sure if you're asking something, or if it's in the background. My apologies, but I couldn't hear. If it was a question, maybe you can just repeat it or alternatively put it on the chat. My apologies for that. I could just hear something, but I couldn't make it out clearly. Okay. All right. But in any case, all right. So let's continue. All right. So you get in front of your patient. The ECG is even done for you, and this is what you see. So immediately, when you see an ECG like this, it's always scary because you start to think, okay, listen, there's a lot going on in this ECG. What's really going on? What's really happening? So let's try and break it down bit by bit. So I always like to start with the ECG axis and we look at lead 1 and lead AVF. So lead 1 is positive, and whichever system you use, whichever way you like to think about it. Oh, no, it's no problem if it wasn't muted. It's no stress, doc. It's fine. But if you need to ask questions, just just ask. It's no problem. So lead 1 is positive, and lead AVF is, I would say it's going more to the negative side because the negative is a bit longer. So we're looking at um, a normal to left-sided axis in this case. Okay. Let's see if we can have a look at our rhythm. So even though we can see there's a lot of ST elevations, that is there. We're not denying that. We're just going through it step by step because this is the habit that you need to get into so that you know how to manage your patient because there may be multiple pathologies on a single patient. Okay. All right. So if we actually have a look here, we can sort of see a P wave in our rhythm strip, but it is very small. So it's not a normal P wave, but that may be due to rotation of the heart, placement of the leads. There's quite a few things. So if you see something like that, it's always best to go through and look at a few other leads and see if you can see something. And when you go through the other leads, you can sort of pick up P waves in a few of the other leads. There they look a little bit closer to normal, but even then, they're not really 100% normal. In fact, they are absent in most of the P or in most of the leads. So, this could well be that we have an atrium that's not functioning, or we've got a very poor atrial signal that's coming through, or whatever it may be. So we can't really talk about a PR interval. We can maybe talk about it here, where it falls within normal. Our QRS complexes are narrow. So that means that the ventricle is getting its signal from the SA node, or alternatively, it's getting it from the junction between the atrium and the ventricle, which is called a junctional rhythm. Now, it's not so important in this particular one, but just for the sake of completeness, we would say, okay, this looks like a junctional rhythm, okay, rather than a sinus rhythm. But it could be a sinus rhythm as well. We'll have a look at the answer just now. So let's just have a look at the rate. So we've got 1, 2, 3, 4, 5, 6. So 300 divided by 6, which gives us 50. So we've got a bradycardia. So whether you say it's a sinus bradycardia or a junctional bradycardia, it doesn't make much of a difference. It now tells us that we have a patient with a bradycardia. Now, I'm hoping in a few lessons to actually cover bradycardias and their management. But just to give you a basic understanding of bradycardias, if your patient is bradycardic and has hypotension, you need to be worried. If your patient is bradycardic and has signs of cardiac failure, you need to be worried. If your patient is bradycardic but is otherwise okay, but let's say has ischemic pain, as in this case, of course you need to be worried. But hopefully we'll get to that when we talk about it. So here we have a bradycardia that's obviously a problem. But the question is, why is it a problem? And I think even if you were to show this to a second year medical student or a first year medical student, or somebody who maybe has seen an ECG once in a while, they'll immediately tell you that something doesn't look right. Okay. So you can decide in your own practice, wherever you're working, whatever sequence you like to look at things. Now, I'm just giving you my sequence because it's just how I've done it over the years. I've been doing this now for more than 20 years. So it's kind of stuck with me. So I'm just going to go through it. So I like to look at the inferior part of the heart first. So that's leads 2, 3, and AVF. And what we can see in leads 2, 3, and AVF are quite severe ST depressions that you can see here, right? So these are quite severe ST depressions. Now, of course, this doesn't mean we say, oh, yes, ST depressions, STEMI, that's the end of it. Let's all go home. No, of course, you have to look through the rest of the ECG, okay? So then I look at leads 1 and AVL. Now, leads 1 and AVL, if you remember from before, they are our high lateral leads, and V5 and V6 are our lateral leads. So just to make it look a little bit nicer, or just to explain to you what I'm talking about. So if this is the lateral side of the heart, okay, let's just say that's the lateral side of the heart. How these 4 leads are looking at it, and this is just a bit of revision. We have lead 5, basically over here. We have lead 6, sort of over there. We have lead 1 sort of in this area, although it's a bit higher, but just for the sake of understanding, I'm just putting it in that area. And we have lead AVL like that, all right? So what we are getting is that we are getting this crisscross pattern. So these 4 basically form this cross along the lateral border or the lateral side. So they are all looking at the same side, just from slightly different points of view. I hope that makes sense. So I like to look at them all together. So I look at lead 1, AVL, lead V5, and V6. And in this case, if we have a look at all of them, what we can see is that the high lateral part of the of the ECG has evidence of ST elevations. And if you look at V5 and V6, we can see it's just affecting V5. There is definitely a little bit of a ST elevation just there. Then we go to AVR, and AVR is sitting on the right-hand side of the body. So here we have a little ST depression. Now, I'll get back to this just now. Here we have V1 and V2, which are the septal leads, which are looking at the septum. We can see a slight elevation in V1, but it's much more pronounced in V2. And if we get to V3 and V4, we see that there's quite an extensive ST elevation as well, although it's the worst in V2. Okay. Now, I just want to pause for a second and just go to a diagram that we have seen before. So if we remember correctly, where we had seen our ST elevations were leads 1, AVL, V2, V3, and V4. Let's leave it at those for now, because I want you guys to kind of learn this, because it will really make life a lot easier for you when you're working there. So let's mark them off. Let me get a nice color over there. So we said leads 1, leads AVL. We have lead V2, V3, and V4. So let's just mark these off here. All right. And if we had to put them on the chest, we'd say lead 2 was just about there. Lead 3 is just about there. And lead 4 is just about there. I hope I'm correct. I'm trying to get it as close to possible, but I'm just using the trackpad and not like a nice optical mouse or something like that. So when we see all of these, the one thing that you'll notice is that all of these seem to be looking at a similar area, even if it's from a different point of view or from a different orientation. So V2, V3, and V4 are looking at it from a horizontal orientation. So in other words, they are looking through the chest, not vertically, but horizontally from where they are. I hope that makes sense. And leads 1 and AVL are looking at the heart from a vertical point of view. So where would we expect ST depressions to be? We would expect ST depressions, let's say for leads 2, 3, and 4. And remember what we said, ST depressions or reciprocal changes are mirror images. Now we know we've got ST elevations here. So where are we expecting to see ST depressions? Would we be expecting one, let's change the color, in AVR? I think we would, because we can see AVR and AVL are sort of across the road from one another, They're mirror images to one another. If we look at lead 1, we would expect it to be sort of in lead, let's say in lead 3 over here, possibly in lead 1. I'm not including the chest leads in here because they don't really affect the limb leads as much. And if we look at leads 2, 3, and 4, even though they are looking at the heart, let's say in a horizontal manner, going in that direction, let's say they're looking at the heart from this point of view, where would you expect ST depressions? You would expect them in similar areas. Okay. In other words, in leads 2, in lead 2, because it's also looking at them from the bottom here. So you've got to imagine lead 2 sort of sitting at the bottom and looking up at what's going on over here. I hope that makes sense. If it doesn't, please stop me. I don't mind. I can always explain it again. But basically what we are saying is that we expect to see reciprocal changes in these leads, okay? Considering that we had ST elevations over here. So let's go back and have a look at our ECG and see if we see this. Now, the reason why I mention this is because you need to know, am I really seeing reciprocal changes or not? So in our case, what we are seeing with 1, AVL, V2, V3, V4, is that we are seeing ST depressions in leads 2, leads 3, leads AVF, lead AVR. So we are seeing what we expected. So this tells us that we have an anterolateral ST elevated myocardial infarction. Okay. Now, do you think this is a mild infarction or a severe infarction? Anybody, you can just guess. You've got a 50%, 50-50 chance of getting it right. So, or let's say a one-third chance. Is this a mild MI? Is this a moderate MI? Or is this a severe MI? What do you think? I'll give somebody a chance just to put it up in the chat. Just looking at them, knowing what we have. Okay. So especially if you look at the amount of ST elevations, or let's say the height of the ST elevations, without working out any formulas or anything like that, do you think this is mild, moderate, or severe? Not sure. Somebody's trying to talk or can't hear you. Thanks. Let's see. Very good. Okay, severe. We've got one answer of moderate. We've got another answer of severe. That's excellent. So whether you put it as moderate or severe, you're actually not very far off. And if you had called it either moderate or severe, you're actually within where it should be. All right. So if it were me, I would say we're edging more towards the severe. Now, there is a formula to work out exactly how severe it is based on the number of blocks of ST elevation. But as a general rule of thumb, the more blocks involved, now you're talking about these little blocks here, the more blocks involved, the higher the risk that the patient is going through. Now, there is an exact formula that you can use to work it out, but I'm not going to bring it up here because majority of the time working in an emergency department, that's not really going to be your first point of call. It's really once you're working in internal medicine and cardiology that you're going to use that formula to actually work out exactly how bad and exactly how much of or exactly where you're going to place the patient in your cardiac care unit and things like that. That's where it comes to. So whether you said moderate or severe, that's excellent. If any of you had said mild, I would have been a bit worried because this is definitely a severe one. Now, these are close to being the most, I would say the most severe ones that you can get, uh, and the ones that anybody should look out for are what we call tombstones, tombstone ST elevations, which kind of look like that. So you may get a QRS complex, but then you get something that looks like that. All right. Sorry, I had drawn it a bit bad over there. All right. So these are the most severe ST elevations that you get. And the reason why they call tombstone elevations is because very often your patient will end up having a tombstone, unfortunately. I know it's a bit of a dark joke, but it's actually quite true. So these are on the border of moderate to severe. But the more important thing to know is that I have ST elevations. I must make sure that I see reciprocal changes as well. And we'll discuss in the weeks to come why that's so important because it affects your differential diagnosis. Before I move on, I don't know if everybody is happy. If you can give me a thumbs up or anything just to let me know, if you guys are okay for now and we can move on, just to discuss one or two other parts of this particular ECG, or if there's anything that somebody doesn't understand, I can go back and try and explain it again. Although if you ask me to explain it again, I will get quite irritated and I will lash out at you. Okay, thank you. No, I'm just kidding. If you're not sure, just ask me. I won't take it out on you. Okay. All right, so let's move on from there. Yeah, no problem. Yeah, if some of you had joined in late, like I say, we were just discussing basically what we are seeing over here from the start. So we looked at the axis and we looked at the rhythm and then we looked at the ST elevations. But more importantly, we were looking at the relations of the leads to one another so that we could determine if we have ST elevations, where should we see ST depression. So that was just somebody in the chat just saying that they had joined a bit late. But yes, you can watch it from the beginning and, I've tried to explain it from there. Okay. So let's move on a little bit. So this was something I had put in the previous discussion as well on myocardial infarction. So this patient now is in front of you. We've determined she's got a moderate to severe MI, and it's an ST elevated MI. So she's already in the high risk segment. So that means all of your attention is going to be focused on her. You're not going to give her medication, go have a smoke, come back, give her some more medication, go and have a cup of coffee and come away. This patient needs your utmost attention until she moves either to a cath lab, if it's available, or if she's thrombolized, or if she's moved to an ICU setting or taken over by your cardiologists or physicians, depending on what situation you work in. Now, in let's say semi-rural to a rural situation, this is the type of patient who you would start with your aspirin, with your TNT, with your clopidogrel. You would get this patient onto morphine. And with an ST elevation that's so high, again, but with the bradycardia, you would again worry about, making that bradycardia worse. So you may opt to move away from morphine in this case. I did get a good question on WhatsApp, which was, why not give pethidine? Which doesn't necessarily slow the heartbeat as much. The truth is that pethidine is actually very bad for your right ventricle. So it decreases right ventricular function. So that's why we've tried to move away from that. So in this patient, we would try and actually control them with TNT. So whenever they get severe chest pain, we'd give them TNT to try and keep it under control. And if worse came to worse, we would, try to, give them a little bit of morphine, maybe a milligram at a time. Now, in all honesty, if this was my patient sitting in front of me, I would be considering her for pacing as well. But that's another story altogether. We're just looking at the ECG for now, not the complete treatment as well. So this is the type of patient that you would follow these. Now, if you want to, this is the type of thing that you can, for example, just take a little screenshot of it and keep it with you just so that you have a basic idea of what to do. But if you've had a chance to download those cardiology protocols that I put up today, it will actually give you a better idea of how to manage this, and in a much more detailed way than I could give you in such a short presentation. So I hope you guys will have a look at those protocols. It's a nice thing just to keep on your phone. It's searchable, so you just type in what you're looking for, and it should take you directly to the page, and hopefully it will help you through with that. So we've managed to get this patient to a point where we are treating her, and we're getting her to our cardiologist, and they're either going to thrombolize her or they're going to do PCI and balloon insufflation. All right. So this is just the answer to what we had. So it was an AV junctional rhythm. So atrioventricular junctional rhythms are quite an interesting topic. Basically, in between the atrium and the ventricle, you can have these accessory pacemaker cells that take over the function of the sinoatrial node and can provide the ventricle with stimulus. And that's why you still get these thin QRS complex that we saw. But we'll see these over the weeks as we are doing more and more of these. So don't stress about this too much, because you get AV junctional bradies, you get AV junctional tachys, you get AV junctional fast. There's so many different AV junctionals, so don't worry about that. So we had a rate of 50 as we worked out, which is a bradycardia, an acute anterior and high lateral myocardial infarction, as I had mentioned to you guys. So the P waves were present, okay, but the PR interval was very short, so suggesting an AV junctional origin of the beats. The rate is typical of an AV junctional origin. ST segment elevation is present in the mid-precordial leads, leading to the diagnosis of anterior wall myocardial infarction. So V2, V3, V4, and even V5 to a small extent. And ST segment elevation is also present in leads 1 and AVL, corresponding to the high lateral wall of the left ventricle, as we had seen. And reciprocal ST segment depression is present in the inferior leads, as we expected to see. That was the most important part for you guys, to see ST elevations and to see reciprocal changes, so that you understand why these two should be taking place and why they are present. Okay. So the presence of reciprocal changes significantly increases the specificity of ST segment elevation for an acute MI. Now, this was one point that I wanted to bring up because I found a lot of doctors do struggle with this sometimes, in that they find that they are seeing ST elevations, but they aren't necessarily seeing the reciprocal changes. And there's two reasons for that. Number one, they don't know where to look for the reciprocals. So in other words, they're not sure where their ST elevations are, so they're not sure where to look for their ST depressions. And number two, they're not considering alternate diagnosis. Now, there are some alternate diagnoses that do give you ST elevations without ST depressions. And then one of the other things that can sometimes lead to this is lead placement. So very often, if leads are placed incorrectly or leads are swapped, and things like that, you need to go back and just check. And this is an important thing. So for example, let's say we have an inferior infarct, but somebody's put AVR on this side and put AVL on this side. They may be expecting to see, for example, an ST depression in AVL, but now AVL's on the other side and they may not be seeing it. So these are the types of things that you need to look for, especially as a junior, because you'll notice not many of your consultants or senior MOs are the ones who are coming to physically put the ECG on the patient. And even when they do come, they're not really looking at where you've placed the leads. So you have to make sure that you place the leads in the correct place. And one of the ones that I've seen that a lot of people make mistakes on are the chest leads. So they tend to bunch up V4, V5, and V6 and bring them very close to the front. So nothing's looking at the lateral wall, everything's looking at the anterior wall, and they forget about the sternum. Now, I'm not accusing those of you on the chat now. I'm just saying these are the things that I have seen over the years that have caused a problem. Now, the last thing that I want to talk about is just ST elevations. Uh, the question is, why do we get ST elevations? This is just a cross-section of a heart. That's your right ventricle, that's your left ventricle. And you can see that this entire section has experienced an infarct, okay? So this is a lateral wall infarct, okay? Now, the question is, why do we get ST elevations? And it's very simple. The injured area of the myocardium becomes active during the diastolic phase when the heart is at rest, and is less responsive during the systolic phase. So basically what that means is that when the heart is contracting, let me just show you here. So when the heart is contracting during the QRS, it has a higher resting potential than when the heart is not contracting. Okay, that's basically it. There's not much else to it. So when the heart contracts, then it doesn't produce as much electricity, which is understandable because it's damaged. All right. So you have this heart that now has this higher electrical state, especially during diastole, and during systole, when the heart is contracting, it's unable to produce that much of electricity. So the difference between those is called a current of injury, and this is what results in the ST segment elevation, all right? And that's what we look for. So when the heart is resting, this here has a higher electrical potential, all right, as they've mentioned over here. It becomes electrically active during the diastolic phase and less responsive during the systolic phase. So that's what creates that ST elevation, and that's what we look for. So it's not some sort of magical thing that occurs. There is a physiological reason behind it, okay? This is just a little joke to end off, and it's 100% correct, although you can do it with just a single incision, and it works quite well, although you will be taken to court should you kill a person using that method. So I wouldn't suggest it. So are there any questions? Is there anything anybody would like to know? Please, I'm more than willing to answer. You can put it on the chat or you can talk. We've still got a few minutes. Zoom has given us a few minutes. So yeah, hopefully if there's any questions, I can try to answer them. If you'd like me to go back to the ECG, I can do that. or to the ST elevations, you can just tell me on which slide you'd like me to concentrate, and then we can answer questions based on that. Or alternatively, if you feel that, listen, I've answered it, I understand this. These are relatively simple concepts when you've been working with this for a long time. But I know a lot of you, having maybe started your careers or you're just a few years into your careers, some of these concepts may be difficult, to understand. So that's why I've chosen to do it this way, so that you can understand these foundational, fundamental concepts that we have in emergencies, although it transcends. I mean, if you're working in anesthesia, if you're working in medicine, if you're working in an outpatients department, in a district level, you need to know all of these things as well. And the one thing I can tell you is that you can know nothing in medicine, but if you know how to read ECGs, everybody will think you're brilliant. I'm a case in point. I know nothing, but I know how to read ECGs very well. Everybody thinks I'm extremely brilliant. So, I can promise you it's a good skill to learn. So if you are willing to, join on a few more. But if everybody's happy, you can give me a thumbs up, or, just let me know if everything's okay. And, then we can, okay, all right. So I've gotten a thumbs up over there. And okay. No, I just want to thank everybody for joining today. I really, really appreciate it. We are going to be discussing open mouth C-spines on Saturday. It will be a little bit later but I'll post that on the group. It's going to be at 5 to 8. Just because I don't want to promise 7:45 when I may not be here. I might just be running a few minutes late. But I hope you'll join me for that as well. And thank you so much for taking out your time. I know it's late in the afternoon or late in the evening. You guys are young. You'll have a lot of things that you'll need to do besides listen to me talk. So I really, really appreciate it. And I hope you guys have a good evening further. And I hope to see you on some others as well. All right. Keep well, everybody. Goodbye.